All right, perfect. Welcome, everybody. Good evening. Thanks for being here today to one of our National Fellow Online Lecture Series. This week's lecture is having to do with sport-related concussion. We have one of the experts in the game here, Dr. Clugston, comes to us from the University of Florida, where he serves as a clinical professor in the Department of Community Health and Family Medicine. He's also a team physician at the University of Florida Athletics. He actually has founded and since has served as their program director at UF as well, and is actively involved in various concussion-related endeavors at both the NCAA level, the NFL level, and everything in between, including the NCAA's Concussion Safety Advisory Group, the NFL's Head, Neck, and Spine Committee, the Publication and Dissemination Committee of the NFL NCAA Research Consortium, and the Concussion in Sport Group. He's previously served on the operating committee and publication committee of the NCAA Department of Defense Care Consortium, as well as the SEC Return to Activity and Medical Guidance Task Force. And importantly for us in AMSSM, he was one of our co-authors for the position statement on concussion care in sport from 2019. For this expertise in concussion and his ongoing work with concussion athletes, he was awarded a joint appointment at UF in the Department of Neurology as well. So very fortunate to have really truly an expert in our field in concussion here to share some wisdom with us. Again, the goal of this lecture is to serve as an adjunct to your home program's educational content. We want to provide our fellows with direct access to educational experiences with AMSSM members across the country and also assist in CAQ exam preparation as well. So without further ado, I'll hand the reins over to Dr. Clugston for a sport-related concussion lecture. Thanks so much.
Thank you very much, Craig. Glad to be here. This is a big topic. I typically go long, so feel free to jump off. You guys out there, I know there's committee meetings. It's getting late on the East Coast too, but we're going to talk about sport-related concussion. I don't have really a lot of disclosures, except the one at the bottom is, my bias is I do take care of contact sports, and I've done it for a while. And my belief in those is that, hey, they're still okay to play, but we need to make them safer. So that's kind of where I'm coming from. We've got some objectives for today. We want to define or discuss what is a sports-related concussion, describe a little bit about its epidemiology and pathophysiology, give you some ideas or discuss some things that go on in the acute management of concussion. We really don't have a lot of time to go in with all the return to play and things that go on in the recovery, but at some point, maybe we can discuss that another time. We want to consider ways that maybe we can prevent this. That's would be a very important issue if we could do it. And then just for fun, I have some slides on some myths that are out there that maybe it helps you talk to your patients about. We'll go through those. And I have 4 or 5 CAQ-like questions at the end. They're not directly related to some of the stuff we're going to talk about, but I think they would be helpful just to run through them. So we'll get to those at the end. Starting with definitions, the biggest group out there where that people pay attention to their definition is the concussion and sport group. It's a worldwide group. It meets usually every 4 to 6 years. Last met in Amsterdam in 2022 and published their consensus statement in 23. And really what I like to tell my patients and athletes is this injury or this condition, it's a brain injury. And I emphasize to them it's caused by a direct force being transmitted to the brain. And for our purposes, for sports related, that occurs during sports and exercise related activities. A little bit different than what you see sometimes in motor vehicle accidents or military activities that are related to blasts. So this injury is a little different for us. I also like to point out that symptoms of this usually present at the time of the impact, but not always. They can evolve or become present minutes to hours later. That's a tough one to deal with coaches. They sometimes don't want to believe that, but we get a lot of kids, unfortunately, these days that kind of report to us late. And I think some of them are being honest when they say they really didn't know anything was going on right at the time. And then a few minutes later, they do. So that part is important to emphasize to people. It can be symptoms that evolve or appear even a little bit later from the impact. Now, as a team physician or athletic trainer or any kind of personnel for sports health, you're not thinking of all those details and the pathophysiology on the field. You just want a brief concept in your mind of what is this injury. And really, the way I look at it is it's a mental status change. It can be really brief or subtle. It has to be related to a force that was transmitted to the brain. But that's a really broad definition. And you can tell with that, we're casting a wide net when we're trying to assume something's a concussion until, or it's at least a concussion, or, and not worse even sometimes, but we're trying to do that until we can prove otherwise. So you do try to assume it's there until you're confident that it's not. For epidemiology, there's a lot of numbers out there. Basically, you just need to know that there's a lot of these in the US. One study showing nearly 2 million a year in high school athletes, over 10,000 a year in collegiate athletes. It's makes up 6% of sports-related injuries. And I like to point out this: is it more common in female or males? It appears in like played sports, so like girls soccer versus boys soccer, that there may be more or higher incidence of this in females. I don't think we can tell you why. There might be differences in reporting, but it does look that way in sports that are played with similar rules. And here's the example of girls and boys soccer in yellow. Basketball, the incidence is higher in girls, but that doesn't mean that they take longer or they have more severe injuries. And there's actually some data out now that shows, and that's from the CARIC study, CARIC Consortium study, and Tina Master at SHOP, showing that it looks like if you take care of these athletes the same and give them the same resources and the same methods of detection and recovery, they tend to recover in similar fashion. So that's important to remember. And I wish we had data on time loss. I think that's a good way to look at injuries, and maybe helps us relate this to coaches when we're trying to describe how important it is to deal with this the right way. But really, the only thing I can find is I think that most people say in the NFL that it's the third biggest time loss injury, kind of behind lower extremity injuries and fractures. But as we go forward, it would be helpful to start reporting time loss or days lost from this condition. What happens when you get a concussion? There's linear and rotational forces transmitted to the brain. That's kind of the big thing I like to hone in on patients. The force, you got hit, usually in the head, but not always, but it got to your brain. This causes some stretching, some shearing of, we think, white matter or axons. This initiates a neurotransmitter and metabolic cascade. Probable or possible accidental injury, blood flow changes. This is a direct quote from the Concussion Support Group Amsterdam statement, and inflammation affecting the brain. This video here shows a good example of a rotational force. It's from the 2014 World Cup. This player from Germany takes his hit, and you'll see he gets whipped around pretty quickly. He wasn't removed right away. It was an unfortunate way it was handled. He came out about 14 minutes later, but he finally was talking to the ref, and he's questioning, am I even in the World Cup? Is this the World Cup final? So he clearly wasn't functioning right, but that's a good example of rotational forces. To depict what goes on at the neuronal level, and this is just one neuron synapsing with another, and you got to remember in the brain there's a billion neurons and a trillion synapses. So wherever the injury is occurring, there's going to be way more than one synapse involved. But just to picture what's kind of going on, we think normally a signal arrives, travels down an axon, neurotransmitters released, signal propagates down the line. In a concussion, you've had a force that got to these neurons. It's probably stretched and twisted, maybe caused some leaking to occur in that axon, and there's a flux of ions. And we think that potassium tends to go out of the cell. Calcium rushes in. Calcium's toxic to mitochondria. This leads to a metabolic crisis, and it takes a lot of energy to put everything back. We feel like people are highly vulnerable to worse injury at this time while they're recovering. And so you have this energy crisis. It's harder to get blood flow in these areas to bring oxygenated blood and glucose, and it just takes a while to turn on the ionic pumps to restore everything back to normal. And hopefully you restore a good deal of it back to normal. There is probably some neuronal cell death that occurs, but after several days, things start to come back a little bit to normal. And then after many days, the thought is that there has been a recovery in the majority of the area where there was damage. Giza and Havda, it's Chris Giza, the group from UCLA, put this out almost 25 years ago, and it still seems to hold true. If you look at the x-axis, that's 100% of normal. So some things go high, some things go low, like cerebral blood flow. The x-axis is denoted in time, and it goes from minutes to hours to days. And you see most things come back around normal 7, 6, 10 days out. But that's not everybody. But in general, a lot of at least the symptoms that people report have gotten a lot better by 10 days. But it's also important to know that not everybody follows that timeline. And these were done in rats, so it's, this isn't human research here, but it seems to match fairly well. I want to switch and talk a little bit about the acute management. And for my fellows, I think that's always an area that when they come in, they're a little hesitant about, how do I do this? Things are happening fast on the sideline. It's chaotic. And so we go over it over and over. And I think our current fellows probably still feel like we haven't taught them enough yet, but we keep trying to go over it. But I also like them to appreciate that when you're on the sideline, you're in a unique setting. And it's not real common in medicine that you're at the place of the accident. And this setting is a place where athletes are sometimes unwilling to tell you that something's wrong. And it's different than when they come into your office a couple of days later, and by that time they've admitted something's wrong. So it's unique, and it's kind of, I think, a special place that you're there when an injury occurs and you can see it happen. So we do like to talk about when to expect. It's not every time you step on the field that you're at a heightened awareness. You need to be thinking about concussion, but there are some situations where it's more likely to occur, and we'll talk about those. We'll talk about kind of methods that you evaluate it there acutely, and then why is that important. So settings where I think that sports-related concussions are most likely to occur, it's not just me, I should say I think, but really it's known that collision and contact sports obviously are going to have more of these, but they can be at any sporting event. Games tend to have a higher rate of concussion than practices. Special teams play in football tend to have a higher rate. And plays that are flagged for targeting, if you go back and look at them, there was a great study from the Pac-12 that showed that there was a much higher rate of injury, including concussion, on plays where flags are thrown for targeting. Preseason tends to have a large overall number of concussions. There are a lot of people involved getting multiple reps. People are there trying to prove themselves. It's a high tension situation. So that's another time to be really on the lookout for concussion. Also high risk practice drills. And there's some drills that are kind of banned by the NCAA. They have a video, it's on Vimeo. It's about 5 minutes, so I'm not going to show it during this talk, but it really shows examples of these drills, and some of them are ones you may have heard of, like the Oklahoma drill and King of the Ring. It's neat to look at. They're drills that aren't really what's going on in the play of the sport. These drills have artificially confined spaces. People can't move laterally like they normally would in the play of the game, and they can't avoid high contact. There's also drills that others have studied that just have found that they have a high rate of repetitive head impacts. So it's likely they may have more concussions. We looked at our drills. We found that all 11 on 11 drills that were run only, and they knew it was going to be a run, and they just pounded each other. This is in football, had a much higher rate of measurable impacts using helmet sensors. So it's theoretical that you would have more concussions in those. Kind of makes sense. And then individually, if you have athletes that have had previous concussions, they are at risk for further concussions. So those are ones that you would particularly pay attention to. Then when you're out on the pitch, it's important to know how to recognize this injury. And I break it into two different groups. Some are very obvious, and they're obvious because of the way they present. So this athlete lying on the field, you're running out there hoping, man, I hope this is just a concussion. He's unconscious. You don't want it to be something worse, but there's no second of your time that you're spending thinking, is this athlete coming back to the game today? So that one's pretty obvious. But the one that's really obvious and sometimes you forget about is when an athlete reports symptoms to you that are related to an impact. You can't look past that, even if you don't even think that what they're saying is true. If they have a headache, it's related to getting hit, that's enough. I mean, you can't move past that. So that they're obvious in that way. But most of them aren't as obvious. Maybe the injury wasn't seen. Maybe an athlete doesn't recognize the symptoms yet. Maybe they haven't occurred yet. They've been a little bit delayed. And then the one you always worry about is sometimes athletes will hide symptoms, and they don't want you to know. They want to stay in the game. And we see that even in athletes that have had concussions before. I sometimes wonder if they thought that the recovery and the return to play protocol was really burdensome, and they kind of don't want to commit to that yet, and they kind of wait a little bit, and then they realize it's worse, and then they finally let you know that something's not right. So those are the challenging ones where it's not as obvious. When you're there, you want to quickly gain information about what's going on. What happened? Did you see it? Was there a mechanism? Was it unanticipated? Did their head rotate? Was there a double hit? Where was the hit? Where on the head, body? And what actions did the athlete do right after this collision? Sometimes nothing, but if you see them do some of these things listed, sometimes it's a clue that they have a concussion. And I have a line that's going to bounce in here. I look at it as the three things above this line: head grabbing, covering eyes, stumbling, or taking a knee, are signs you need to pay attention to. They don't, they don't, they're not specific to neurologic damage, but the things you need to pay attention to. The things below that line: disorientation, the loss of consciousness, fencing response, or tonic posturing, convulsive movements. There's no question that those involve some type of brain injury. So those are very important signs to look for. So all those things you need to look for. And then you got people to ask usually. If you're there and there's other people, an athlete trainer, someone around, you want to ask them, did they see it? What do they think is going on? Do teammates recognize that this athlete's not acting right? If you have spotters, I think it's helpful. Video review is helpful. If you have it, you need to go look at it. And then sensors, I don't think those are really helpful yet. We use some form of sensors. We have mouthpieces, we have helmet sensors, but there's not really a threshold that we would say, oh, over a certain G force or rad for rotation that has to signify concussion. They help us maybe track impacts, and maybe someday they'll be more helpful in the actual, detecting of a concussion. But right now, it doesn't help us a great deal for detecting a concussion at that moment. So you get to the athlete. You've considered all those other things we've talked about, but now the athlete's in front of you. You got to think about your standard first aid. It's ABCs. You got to look for red flags, things that are signs of a real severe injury. I'm always thinking C-spine injuries. You need to assume it's there if they're not lucid. You also see facial injuries and skull fractures and eye injuries. You got to be worried about a structural injury or intracranial bleed. And if you're thinking one of those things is there, those are things you don't want to take care of on the sideline or in the locker room. You need to activate your emergency action plan and get them out. But most of the time, you're not dealing with those, and the athlete is stable, and you're starting to consider, is this person concussed? So I like to ask the athlete what happened. You want their version. It gives you a clue of how their attention is, how's their speech, how's their memory. A common question to ask them is, what happened, and then where did you get hit? I like to ask what symptoms they have. NFL reports that if you looked at their athletes that were concussed, the top three symptoms they report are headache, pressure in head, and don't feel right. So those are three I definitely like to ask: headache, pressure in head, and don't feel right. I'll also ask, has your vision changed? Is it blurry? Do you feel dizzy? Do you have neck pain? You need to be able to kind of list off these symptoms, you can't just ask them, how do you feel? So you have to have yes or no things. Do you have a headache? Do you have pressure in your head? You don't feel right. At the same time I'm asking that, I usually reach around, I'm palpating their cervical spine. If they do not have midline tenderness, I feel better about checking the range of motion of their neck and then strength. And you can do all this pretty quickly on the sideline. And then I want to check their cognition, and I kind of break that into three things. I think memory and orientation and then concentration. Memory, I like asking, do you remember to play? What was your responsibility? They usually should know that. I like asking them, do you remember coming off the field? And you'll be surprised how many of them don't, or they don't remember who ran off with them. You could ask things like, what did you eat for breakfast? Things that they normally would remember. Maddox questions are good, especially for game situations. They don't always apply to practice. So you need to come up with some questions that are worth asking it in any environment, really. But the Maddox questions are listed on the SCAT-6. Orientation, don't make it too hard, but like what day of the week, what month, where are we, what city, who's our opponent, things like that are usually something that every athlete should know. And if they don't, there's an issue. And then concentration, asking easy things like days or the week backwards or month backwards. You can have them subtract numbers from 100. I make it easy. I usually just do serial threes from 20. It's very important if you know the athlete, you're ahead of the game and figuring out if something's wrong. So a lot of times you may not know them as well as the athletic trainer. So having an athletic trainer that does know them really helps you in many situations. So you're still there on the sideline. You've kind of gone through the memory questions. You're kind of getting an idea what happened to them and what they're feeling, but you want to check a few other things too. And balance or gait is really important. And you'll notice I haven't pulled out any like the SCAT forms or things I've done baselines on yet. That's coming. This survey here is really something I do quickly because sometimes they're not concussed, but you got to do enough to get an idea of what's going on. So balance or gait, I may have them just stand in a tandem stance, put their non-dominant foot behind and their dominant foot in front and stand there and put their hands on their hips while I'm talking to them and asking them things. I'll probably check pursuits with their vision, just doing an H while I'm having them stand in that position. So you can do a couple of these things at the same time. If their balance and looks pretty stable standing in that position, I'll have them close their eyes, take the visual cues away and see how they do. For vision, I do like to check one eye at a time and have them read something in the distance just so I know that that's okay. And then I'll quickly do some ocular movements. I just showed you the pursuits. I'll do really all the VAMS maneuvers. If you're not familiar with the vestibular motor screen, you should be familiar with that. It was designed for a clinic-based exam, but I think a lot of us have adopted those maneuvers, at least the maneuver part of it, for part of our quick sideline exam. And I find it to be helpful. And then photophobia. It's easy to turn your cell phone light on and you want to see their pupil reactions anyway, but sometimes if you do that and they're really moving away or they're falling out of that tandem stance position just because you're turning the light on, that kind of gives you a clue that things aren't working correctly either. Cerebellar function, that's also easy to do, finger and nose. And then if I really haven't found anything wrong with them and their story is convincing that they're okay, and there's a possibility that they're not concussed, and this is not the usual situation, but if you're in that situation, you got to exert them before you ever think about somebody not being concussed and is there a chance that they could return to play. I like doing some quick jogs, but then doing burpees or up downs. You want their heart rate to get up, and then you can repeat some of this exam. If you do that exertion and they say, yeah, I don't feel good, I mean, you don't have to do any more. You got your answer there. And you need to make some decision. You don't have to make a total decision whether they're concussed at this point, but you got to make a decision. Is this somebody I need to take back to the locker room? And some things to think about there is take your time. This is coming down to you to make this decision, so don't rush it. Depending on the sport or situation, you may not even have to make this decision quickly, but sometimes you do. But think about the setting you're in, and I say account for your contextual susceptibility. Are you being deceived by an athlete that's trying to play when they're injured? And that's very possible. Are you letting your human side come out and you're a fan of this team and this is the star player and he doesn't look that bad and it's a championship game? Like, you got to think about it. Am I making a decision that is not objective as possible and rational and not in the best interest of this player? So really slow down and think about what you're about to decide. Fortunately, a lot of this you can take and then get more time and you go on to a secondary survey in the locker room, which is what happens the vast majority of cases. If you were to say, I'm not taking them back further, or I think they could return, you do need to keep looking after them the whole game. So we call it serial monitoring. And remember that the presentation or symptoms of a concussion can evolve or change, and so can a worse injury too. So no matter what decision you make here, you got to keep looking at them throughout the rest of the event. So the vast majority of them, I'm not convinced that they are fine. Some of them, it's easy, it's obvious they're concussed, but a lot of them, you're still kind of wondering, this guy doesn't seem right, but he's trying to tell me that he's good. And my little brief exam there, he did pretty well on it. Um, I then moved to like a secondary survey, and I know that not everyone always has a locker room or a place to take them to. Um, but kind of plan out your environment. Where would you do a secondary survey? Where would you do the first one? We do our first ones usually in a tent now. It's a little bit quieter and more relaxed than out in the open for sure. But the best place is getting them back in a locker room. So we try to walk them back. Gives you time to observe how they're walking. Are they paying attention to you? Are they getting emotional? Sometimes the sideline nervous anxiousness kind of melts away as you walk in. And then you can do a much better and more detailed neurologic exam. I've kind of listed some of the things you would do there. And this is also the place where you would perform your baselines. You spend all the time doing baselines, you need to use them. Uh, these usually include a symptom inventory, some component of cognition. For us, it's the CAQ, which is part of the SCAT6. We do use a program called C3, so it's on an iPad. But these tests are open domain. We use a 10-word immediate and delayed memory test that's on the SAC. And then some form of balance. We tend to do the modified BESS depicted here, and we have a little belt that we use that monitors movements off the center of gravity. Time tandem gait is another one we like. We do that in our clinic. That's just a picture of it where you time an athlete walking in tandem down the line and back. Do 3 trials and we take an average. I'm not doing that in the locker room because we don't travel with that, but I just put that up because you do see that on the SCAT6 as an option. We love that in clinic. And then I try to do a full VOMS. I kind of did those maneuvers briefly out in the field, but here we'll pull out a sheet or on the iPad and we'll actually rate their symptoms and see, do they get worse when they do these maneuvers? Some people like rapid automated naming tasks like King Devic. That's like an easy and quick test to do, and there's eye trackers and things, but we're not using those. And then you compare to the baseline. And often it's helpful to kind of show an athlete, you think they're concussed, but it's really helpful to show them, hey, here's your score right now, and it's significantly worse than what you were at the beginning of the season. It just helps you when you're explaining things to them that they're injured. And very rarely, again, they make it through this and they're okay, and you realize, wow, they just got poked in the eye, and I think that they could return. It's unusual, but it has happened. And again, on those, you're going to really need to exert them. And here you've had a good 20 minutes or so by the time you've done these to really follow them and see them. So, it's up to you to make that decision there. And by this time, you're at least having to make a decision whether they're going back in, or it's either a concussion or a suspected concussion. So you do have to come up with more of a definitive answer by that point. And then you repeat, monitor them just like you did, like we mentioned before. These symptoms evolve. If they develop neck pain, numbness, severe headache, double vision, seizures, they seem like they're stumbling, if they're just acting out right, we get them out and we get them to the emergency room. And sometimes if they've had a persistent, like they're perseverating, they keep asking the same question over and over and over, and that hasn't gotten better throughout the whole monitoring, I would consider sending them to the emergency room too. It's good to give some guidance. If so, say you've made this diagnosis, they're concussed, and now the event's over and people are going home and they're going to go home with either a roommate or family member. We don't want our athletes to be left alone for that first 3 hours. And parents will ask, like, how long do we need to monitor them? Do we wake them up in the middle of the night? When we say no, but I at least want someone to be with them for that first 3 hours and to know that they need to look for those worsening symptoms. They should not be sent home by themselves. They should not drive anything with wheels, so that's scooters, bikes, cars. They should not use alcohol, recreational drugs, or medicines that aren't prescribed by a healthcare provider. But I do tell them that taking Tylenol is okay, and there's some evidence that's, I think, soon to be out. I've reviewed a paper showing that Tylenol, possibly other anti-inflammatories, were good in the acute period. I think it was driven more by Tylenol, but we've for a while been leery to put people on NSAIDs for risk of increasing a bleed risk. But it does look like Tylenol is very safe, and there's some evidence that may be associated with a more rapid recovery. So we do encourage our athletes, if they're having headache, right after the event, to go ahead and use some Tylenol. This is a depiction of what happens. We've kind of gone over it, and you'll see that the impact occurs. You're evaluating them. Most of them are suspicious, which is the big fat blue arrow. You go in the locker room, suspicious, reevaluation, but a lot of these go into this big red concussion box here. There's a few that you're convinced they're not concussed and they could return to play, but even those you want to serially evaluate. Some general thoughts on this. This system is not perfect, right? We don't have an objective, truly objective way to look at this injury even now in 2025. And with the known fact that they can have delayed symptom presentation, and some people are going to just not report, I think it's impossible to really get to where you detect 100% of concussions. I think we're fooling ourselves if we can do that, but we need to strive to be as close to that as possible. And I think we can get pretty close. I find it interesting that the NFL actually does, and this picture is their game day checklist. If you get a chance to look at it, they've published their protocol, and it's pretty neat to read through it. But they actually do concussion evals. If you have a stinger, you get thrown in their concussion eval group. But with that group, they do about 4 evals for every one diagnosed concussion. So they're casting a really broad and big net. And I think that's an important concept. Not everybody that comes to you is going to get a concussion diagnosis. Most of them will, but not everybody. Why is it important? We really think if you do this right, you're going to decrease the chance for further injury. There's evidence that concussions are associated with lower extremity injury afterwards, but it makes sense that even in that acute period, if you're going to have reduced motor control, reduced reaction time from this brain injury, you're going to be more likely to suffer another injury. You're less able to protect yourself. And then obviously you're at risk for a worsening brain injury. And that's Zachary Lystat there. Many of you are familiar with his case in Washington, and he had a second impact syndrome is what we think there. Those are not real common, unfortunately, but if you don't detect these and remove people, people are at risk for worsening injury. Also, a thing that you can list under importance for removing and figuring this out soon is if people do stop activity right after the event and seek treatment, they tend to return to sports sooner. This paper from the CARE Consortium showed that if you did this in all sports, so not even contact sports, if they stopped exerting right at the time of the injury, they returned 3 days sooner. And that injury group includes people that had loss of consciousness, because they had to stop because they were unconscious. So that you would think they might even have more severe injury, but they're in that group that showed a 3 day sooner recovery. They had less severe acute symptoms, and they had a much greater chance of full recovery at 14 days and at 21 days when you looked at those people that took that long. I also have been in discussions where NFL people have kind of noted that after a game on Sunday, if it takes 2 days to report, so say they don't find out about it until Tuesday, there's basically 0% chance that that athlete is going to recover in time and be able to go through the protocol to play the next game. So it's way better to know about these soon, tell your athletes, have them know about this, and coaches know about it, and get working on it sooner than having it go undetected. Despite all that, we still find athletes that delay, but we try to educate them. I want to spend a little bit of time on prevention. If we could prevent more of these injuries, it would be great. And there are some things that do help. You think about it, it's important to decrease just the impacts to the brain. So if you can decrease impacts to the brain, you're likely going to decrease the number of concussions. Many ways to look at it. Some people have made important rule changes. The NFL kickoff rule change, I think, has kept that an exciting play. If you talk to people from the NFL, they have shown that they've driven the injuries on that play down to the injury rate is down to what a regular play would be, whereas in the past, it had been their most injurious play. Calling targeting, and I think that has helped. This is an example here where they don't call it on the offensive player. So I always like to point out, I think it's important to try to encourage and argue for this to be called on any player that lowers a head and does that. So limiting exposure in practice. Dartmouth and Coach Buddy Stevens were famous for developing robots that they tackled, and they were Ivy League champs when they did this. So it didn't seem to decrease their level of play, and they could tell parents, "Hey, your son's going to play here, and they're not going to really sustain an impact to the head from a teammate." If you can modify rules in practice, that would help. It's a tough thing though to be able to go to a coach and say, "Hey, you shouldn't do that drill." But we're starting to get more and more data on what drills produce the most impacts, and maybe you can suggest, let's do a couple minutes less of that drill every time. Impact monitoring. I'd said earlier that these ways to monitor impacts or measure impacts probably aren't going to help us detect a concussion at the time. But it's feasible that by monitoring these, you might be able to come up with some metrics where a player looks like they've taken more hits in a week or over a certain time period or in a day, or that you say, hey, they're maybe a little more susceptible to an injury. They've taken this many hits already, so you back off. You can kind of look at their load. This picture here in the center is a helmet monitoring system now that's in some of the newer Rydell helmets. Probably has a ways to go. There are a lot of teams that are kind of looking at it, but I've yet to hear anybody that's really used it to modify practices yet. But it's out there, and it's the charge lasts almost the whole season, so it's pretty easy to deal with. The mouthpieces here are ones that have been looked at with a NFL NCAA study. Mouthpieces are hard. There's a lot of work to take care of, but impact monitoring may help us in the future. Other things that could help, we think vision training, improving your peripheral awareness, especially combined with neck strengthening, so you can anticipate an impact and strengthen or fire your neck muscles before the impact occurs, may decrease the force that gets to the brain. Equipment improvements. There has been a lot of change in helmets over the last 10 or 15 years. This may be helping. It's hard to really prove, but it does. If you just look at the NFL data, they feel like theirs have gone down. The use of Guardian caps is controversial. A lot of teams use them. We use them. The NFL has some compelling data, and there's some data from high schools and colleges that say they don't feel like they help a lot for reducing concussions, but that's out there. The cervical compression collars have FDA approval to reduce the effects of repetitive impacts. They can't say that they reduce concussions, but those are out there. But unfortunately, they cost like $200. Helmet ratings may help us reduce concussions, and have really driven innovation in helmet manufacturing. And helmets that were green at the start of these ratings are now falling off into red. So You got to think of things about expenses though, as these ratings come out every year, and there's different ones on the top. But if parents are asking, I do show them these ratings and say these may be better helmets for your your athlete, and they do have position specific helmet testing now. Getting close to the end here. So impacts to the brain that we want to decrease. You can also think about playing surface. I think most of us are aware of impacts like this. Really not hitting the head, but slam down. And if you noticed or looked at some of the quarterback specific helmets that are out, they have extra padding in the back of the head there. So playing surfaces can have an effect on injury rates. There's now some evidence that associates concussion reduction with mouth guards in ice hockey, at least youth hockey. Whether that translates to other sports is we don't know yet, but that's in the statement from Amsterdam that that's a preventive strategy that has some evidence. Neuromuscular training, at least in rugby, is shown to reduce the rate. Whether that applies to other sports, we don't know, but it doesn't seem like it's a bad thing to do. A lot of those were more ACL type reduction, neuromuscular training programs. I wanted to go into a couple myths, and these are things that maybe it helps you talk to parents and athletes about. One, is it okay, or the myth is that it's okay to keep playing after concussion as long as you do not sustain another hit. And we did touch on that earlier, that that's false. So multiple studies from contact sports, but also non-contact sports, have shown that just continued exertion, regardless of whether you take another hit, is associated with longer recoveries and higher symptom burden. So I still hear that from players. Well, I didn't take another hit, but I still tell them, hey, well, we still don't. We have evidence that if you keep exerting and don't come out right after this injury, it may take you longer to get better. Myth number two, that to recover from a concussion, it is appropriate to have complete rest, both physical, cognitive, social, until asymptomatic. I think everybody on this call would realize that's got to be false. And I put this little picture of a really thin window because we just talked about how you got to stop exertion at the time of the injury, but it's only for a short period of time. So it's a narrow window of that, really, where you're shutting down. So that statement about complete rest was false. So once symptoms have stabilized, that means like no longer worsening. There's pretty good evidence that low intensity activities with a gradual progression back to normal are thought to be the most useful. John Letty from Buffalo has done amazing work showing the benefits of aerobic exercise and how this improves brain recovery. So I like to tell that to patients and make sure that they're doing it appropriately, which is very low intensity to start, and they're monitored, but to not feel like that they should not try to do any aerobic exercise. And I also give them that advice with reading and studying. You want to start slow and small time quantities, but it's okay to try things. Myth three, impact sensors alone can detect concussion. I think we've gone over that. No, they haven't been found useful as of 2025. There's really a wide range of force that produces concussion. If you look at what force was measured in different people that were concussed, sometimes it's surprisingly low, and other times it's amazing how big a force somebody sustained and wasn't concussed. So it's not really useful right now. And part of that, we're still not able to measure the force it gets to the brain. So we're just measuring what's on the inside of a helmet or in the maxilla, which is the skull. You know, it's getting closer, but it's not what's really getting to the brain. And also the reproducibility of the measurements is not felt to be as reliable as it needs to be yet in some of these methods. So that may be another reason why it hasn't been useful. But it is probably helpful when we want to quantify numbers and the locations of impact. So I'm not saying that these sensors have no value. I think over time we're going to figure out how they do help us, and as they become more readily available and less expensive, we may see more of them. All right, myth four, retirement is mandatory after 5 concussions lifetime or 2 concussions in a season. I get this a lot, and I already get this magic 3 concussion lifetime rule, not just 5. And that's not true either. So there's really no magic number. Making a decision about retirement for that season or for lifetime is really a process that involves a lot of input. It's a shared process. Definitely has to involve the athlete, usually parents, coaches, you as a sports health staff. And it needs to include factors such as how severe were the symptoms, how long did it take someone to recover, was there less and less of a force required to produce an injury with the successive events? What's the athlete's long-term goals? Is this activity something they need to keep doing? Also, got to think about, we want them to stay physically active, and if they're retiring from this, are they going to be able to find other things that they can stay active with? So there's a lot of factors, but no, there's not a magic number. And then, does a fencing response signify a worse concussion? And if you're not, I think most people are familiar with it. There's this video, you can look it up online. There's some pretty cool videos that show how dramatic this looks, but it's a reactivation of a newborn reflex. And Tom Savage here is laying down and kind of in that position that you sometimes see with the fencing. Usually it's one arm out and one arm in. But does that mean it's worse? Actually, no. It looks terrible. Yeah, it's awful to watch. But a fencing response after a concussion was not associated with a prolonged symptom recovery or increased symptom severity in professional American football. And that was Dave Okonkwo at Pittsburgh, and his group looked at this in the NFL, and they had 57 fencing response events. They matched it with each of those events. They matched with 2 other non-fencing concussions of the same position, same concussion history, and looked at their recoveries. And so they really didn't find that it signified that it was a worse injury, which is good news. But so this myth is false that that's worse. But if it does occur, there's still a 100% chance that there's a brain injury going on. So as a clinician, it's another thing that helps you see the injury, but it's still awful to watch. So, all right, that was all the myths I had. We'll run through a couple CAQ-like questions, and some of these aren't things we talked about directly tonight, but I think most of you can get the answer here. And I'm not sure if Andy had a way to do a poll. I'll read through them. I guess there it is. Okay, so you can click A, B, or C on the answers there. So which of the following is required to make a diagnosis of concussion? Abnormal findings on a brain MRI. B, history of or witnessed event where a force was transmitted to the brain and produced a mental status change. C, loss of consciousness. D, both A and B. And E, B and C. There you go, B. All right. We got pretty much 100% because everybody else didn't. There wasn't oh no, there's an E. Okay. Yeah, we didn't go over this on the talk. I give this to all to med students and other people we talk to, but a lot of people still feel like, don't I need to get a scan of my head? And I explained to them that, hey, if we were to scan you acutely, it's not going to be an MRI anyway. It's going to be a CT. We're looking for structural injury. But now you're 2 weeks out in the clinic and you're not right, and but you've gotten somewhat better. Don't I need a brain MRI? No, we really, in a concussion, we have not found benefit in routine MRIs or CT when we need to make that diagnosis. I'm not saying you don't image ever, and there are times we do it, but acutely, if you're going to image, it's usually a CT, and most of the time, we're not ordering those. We haven't felt the need to do it. Loss of consciousness, obviously that is at least a concussion, but you often don't have loss of consciousness, but you can still have a concussion. All right. Delayed removal from activity after sport-related concussion is associated with A, decreased time of recovery and decreased severity of symptoms in those who continue participating but do not sustain additional impacts. B, increased time of recovery but similar symptom severity compared to those with immediate removal. C, increased time of recovery and increased symptom severity compared to those with immediate removal, regardless of whether they sustained additional impacts. And D, increased time of recovery and severity of symptoms only in those who sustained additional impacts. Good job. C is the majority have chosen that, and that's the correct answer. So really, it doesn't require an additional impact. It's just the fact that they kept exerting, usually at a high level, that can make these symptoms take longer to get better. And it's still amazing to me that that group included people that had the worst looking concussion. So the immediate reporters or the immediate discovery ones, if you had loss of consciousness, you're automatically immediately discovered. And even being in that group, the finding was still pretty significant in multiple studies now. In American college football, sports-related concussions occur most frequently per player per play during A, spring practice, B, August training camp, C, regular season practices, D, games, E, postseason practices. So remember, this is asking per player, not the total number of concussions in a period of time. All right, we got some variability in the answers here, and I know my talk wasn't really about this. So the answer is going to be games. So D. So this is per player per play. So it's, there's not a lot of people on the field at one time. There's only 11 on your team at one time. And so the number of the player exposures are small in games relative to what they are in practice, or especially preseason camp, August training camp. But there's still a high number of concussions. So the rate is the highest in games per player, but probably the overall rate is highest in August training camp. But you got a lot more people doing, getting reps and stuff then. So both of those are areas you could look to improve. You can make the game safer, maybe by rule changes. You could make August training camp safer by maybe changing up drills or having more non-contact days, things like that. Okay. Which is a true statement regarding gender, sex differences in sports-related concussion? And we didn't talk about this really either. Or maybe I mentioned a little bit, but women have women have traditionally been understudied in sports-related concussion, but it appears their incidence rate is significantly lower than men in like-played sports. So women's soccer versus men's soccer, women's basketball versus men's basketball. B, women have traditionally been understudied in sports-related concussion, and it appears their incident rate may be higher than men in some like-played sports, but more studies are needed when concussion education and access to sports healthcare is similar between women and men. C, women have traditionally been overstudied in sports-related concussion, but it appears their SRC incidence rate is significantly higher than men in like sports. And D, women appear to be more susceptible to sports-related concussion than men, but report fewer and less severe symptoms. All right. B has it, and B is the correct answer. I'll start with C is obviously wrong because they've been horribly understudied, not overstudied. So that's wrong from the first phrase. B is incorrect because it does appear that that women may be more susceptible to SRC, or at least there is a higher incidence than men, but they don't tend to report fewer and less severe symptoms. There is some evidence that their symptom reporting is higher, and we did not talk about this, but they may notice things more. They may be more truthful. Don't really know why, but they tend to report a little bit higher symptoms, but they still recover at the same rate in environments where they're getting the same care. So that's incorrect just because it said they report fewer and less severe symptoms. And then A is incorrect because Um, it's saying that women appear to have a lower incident rate, which we don't think that's true in light played sports. So B was the correct one. And I think that's all I have. So yeah, I want to thank you guys for paying attention and hanging in. I know it's late and it was a long talk. So, and I can stay on as long as there's questions.
All right. Thanks very much, Dr. Clugston. That was awesome from start to finish. I think really high yield for our fellows, especially in this busy season for all fellows at every level of football and other contact sports right now. So we have a few questions in the chat. First question actually stems from your point about the impact or where the athlete is impacting. Is there any research that you've seen concerning turf versus grass fields and concussion rates?
That's a really good question, and it's really hard to answer because there's so much variability in the turfs. Um, even a grass turf can get really hard if it's not maintained correctly. And a turf field or field turf, so it's artificial. Those have different infill sometimes, or some black padding underneath it, and some of them are, a school may put that in to save money, so then every single sport uses that, and it really gets it packed down, and they don't do the proper maintenance, so that could be really unsafe. Um, I know from some of the meetings I've sat in that there's talks about some of the professional leagues really trying to standardize turf and having requirements that you have to meet to host games and stuff. And I think you may get some data once things get more standardized where they can compare all of our grass fields are one way and all of our turf fields one way and then looking at it. But for now, both situations, if they're not properly maintained, they have a higher risk of causing injury.
Certainly, too, like natural fields in cold weather climates versus warm weather climates going to be a lot different.
Yeah.
Also, really a lot of
Can't,
variables there for
I
sure.
don't have much experience with that, but I can imagine if a field's frozen, it's got to be tough to hit your head on.
Absolutely. In your experience with sideline concussion evaluations, what signs or symptoms make it a non-negotiable ED referral?
Well, so if someone there's multiple ones, so this may take a little bit to answer, but if it's loss of consciousness and is not brief, and you may think that 5 or 10 seconds is brief, but man, that seems like a long time when you're running out there. So anything over a couple seconds for me, I would like to remove. I'm less comfortable with that. Um, Ones that have occurred where the athletes seem to deteriorate a little bit, ones that have happened more in my career are vomiting. Um, we get to the airport and someone that we know has a concussion all of a sudden starts vomiting. We're not going any further with travel. We're sending them back and getting help going to the hospital at the site. Perseveration, so where someone is just keep asking you over and over, Doc, did I fumble? Doc, did I fumble? And that's not going away. We've sent those. Um, if there's anything on your neuro exam, there's an unequal pupil or their eye tracking seems really off. I have a low threshold of sending somebody on to emergency room. I say most of these don't need scans and things like that. And most don't, but I do have a low threshold of sending. It's mainly any persistent neurological deficit or any of those red flags, you got to send them.
Those parameters change at all, when you talk about traveling from an away game. So if you're a few hours out from this injury and you're about to get on a plane, right? Is there anything else that you're taking into account, or it's really, like you said, those deteriorating neurologic exam, a neurologic deficit that you note on your exam, or some of those other red flags? Are there any additional things that you're taking into account there?
Well, a lot of it is, unfortunately, a lot of it we've had at least 2 hours with somebody before, by the time the game's over and you pack up and you're getting on a plane. A lot of times you've had more than that. And if you haven't seen a deterioration about in that length of time, you're feeling pretty good that, hey, it may be safe to go. Um, but if there's any question, and we're in a high resource situation, so it's not that hard for us to leave someone back, and you leave a GA athletic trainer back with them, or someone's with them. And you also know the team physicians at the schools, and they're helping you out. So we're pretty lucky that. So it's really easy for us to leave somebody back. Um, but there is really no evidence that a stable concussion has any issue flying. And that used to be a question. Is it safe to fly after a concussion? And it really is if they're stable. Uh,
Awesome. And then just one more question here we have so far, and anyone else still on the call, feel free to chime in with any additional questions. Would your approach change when evaluating athletes who are competing in an individual sport, especially if they're competing in an elimination round or there's a limitation on time for medical, timeouts or things of that nature, like in wrestling or other combat sports? And it's too difficult to have a real extensive evaluation in that time. Or if it's too extreme to pull 100% of these athletes out after any kind of head trauma. What kind of goes through your mind in making some of those decisions?
well, first, before I even cover the event, I'd be hesitant, and it's so easy for me to say because I'm not really covering an event that has that time stipulation. Um, but if you're in that setting and you really didn't have any choice, and all of a sudden you're there, I mean, that's tough. I think you got to really think long term. Like your main responsibility is the health and safety of the athlete from the point you're seeing them forward. Um, and it's tough when you're thinking, am I affecting this person's ability to compete or win a championship? Is very important to this person. But you have to come at it like my job is to keep them as safe as possible. And the vast majority of situations where it's been really contentious, and an athlete or the parents or people are really mad at you, um, I've found that given some time away from that, and sometimes it's only a couple hours or overnight, but you get some time away from that, and they realize you were doing the best thing from your training, what you thought was right for that person, and you weren't doing it maliciously to hurt them. And I haven't found anybody that has stayed mad at me for a lifetime. Like they they're going to see that you're really trying to do the best thing for them. So you got to kind of keep that in the back of your mind. I know they are so mad at me right now, but I really don't think it's safe for this person to go out, and you got to make your call, and you got to sleep at night too. So, um,
Absolutely. Yeah. Well, again, Dr. Clugston, that's all we have from questions so far. We all really appreciate your time this evening, and thanks for hanging with us, even guys, as we've gotten a little bit over our typically scheduled allotted time, but this was well worth it. Really, really high yield and a super awesome talk.
thank you.